how to take an obstetric history, again by an obstetric registrar. I'll be giving you some tips on what kind of questions you need to ask, what is the information that you will need in hand before you go and discuss this patient with the senior. So, for an obstetric patient, you want to start off by asking their age. You want to then know the patient's gestation, so how many weeks pregnant they are, because the number of weeks they are pregnant really will influence the management that we offer this patient. So whether they are 20 weeks or 28 weeks or 37 weeks has a huge implication on management. You then want to know if they are over 20 weeks, whether they've felt any fetal movements. Then you want to find out if they're experiencing any symptoms like bleeding or pain in the pregnancy or any other presenting symptom that the patient has come to you with. But generally and quite commonly would be either bleeding, pain, or reduced fetal movements. You then want to know if the patient's had any obstetric scans in the pregnancy. So have they had their dating scan? Have they had their congenital anomaly scan? Have they had their if they're on a growth pathway and they've had any 28 week, 32 week, 36 week, so any further scans in the pregnancy. So somebody who's being offered any extra scans in the pregnancy will either implicate that they have had a medical problem or an indication in the pregnancy that would warrant those extra scans. You then want to know if they've had any problems in the pregnancy itself. Things like GDM, that's gestational diabetes mellitus, things like preeclampsia, which is high blood pressure, any antepartum hemorrhage shortened to APH, any previous pregnancy complications. So when you find out their gestation, you also want to know their parity, because if they are a para 2 who's had 2 previous cesarean sections, the kind of management of options available to them differs to somebody who's had previous to normal delivery. So find out about their parity, but also the mode of delivery that they had last time, if they had any children previously. Complications in this pregnancy help then determine what management the patient will be offered. You then want to know other things like any relevant medical history, surgical history, social history, things like alcohol, smoking, any allergies. Now, the good thing about obstetric history taking is if you are in a place like maternity assessment unit, antenatal assessment unit, which it's called in some hospitals, the midwives will already have taken some of the history for you. So they'll find out the patient's BMI, the patient's parity, the patient's gestation, why they've come to the hospital today, they've had their observations taken. A lot of the information will be written down for you. Even in some hospitals, they'll take that down any past relevant medical history or any obstetric complications that the patient's already had in the pregnancy. So that really helps tailor your questions when you go and ask the patient, but always double check things are written down, because errors can be made and you don't want to presume that whatever is written is correct. But so equally double check things when you go and speak to the patient as well. You then want to find out about the patient's BMI, whether they've had a fetal heart auscultation, so whether it's just, with a CTG or not. A urine dipstick test gives us lots of important information in the pregnancy, like, for example, presence of proteinuria or any signs of urine infection, like nitrates, leukocytes, and then the observations of the patient. So things like the blood pressure, the heart rate, the temperature, the rest rates, all help in making a management plan. In terms of examination, speculum examinations are safe to be done in pregnancy. They should be done in a sterile way, which means you use sterile gloves for it, and the speculums should be done in from taken from sterile packets, and again, vaginal examinations may be relevant if the patient was contracting and you think the patient might be in labor. Usually, a senior may help you with this examination. Abdominal examination is relevant because even in pregnancy, you get other pathologies like appendicitis and cholecystitis and pancreatitis and all other problems that happen outside pregnancy also happen during pregnancy. So feeling the abdomen is also absolutely crucial. It also helps you to palpate the fetus and the lie of the baby. It also helps you to measure the symphysis fundal height, which you would then plot on the growth chart, and it will help you enable you to inform you whether the baby was growing well for the gestation or not. So that's it really. If you think about it, it's not really very complicated, although it is an area that doesn't get to be covered in any other parts of your rotation. So you will naturally feel a bit apprehensive when starting your obstetric rotation. But I just want to tell you that it's not difficult, it's not hard, and and this is a simplified version of the history taking, and there's lots of people around to support you, like your registrars and consultants. And midwives have wealth of information because of seniority and the number of years that they have worked in obstetrics. So do use and get some information off them in terms of where to find important information that you will then need to inform your registrars of, who will then help you make management plans and take it further.